Thank you so much, Professor Zhang, for your introduction. So in my presentation, I'd like to address the toxic side effects of ART. And you can see that from the WHO guideline, they always say that the DTG is so good. In this presentation, I will focus on the toxic side effects of drugs. So I will talk about the other side of the drug. So hopefully this will not make you upset. Okay, so there are 4 classes of toxic side effects. So you can see that the first group is NRTIs. They are the backbones. What are the NRTIs and what are the toxic side effects? The first is AZT. So the first is bone marrow suppression, including high lactic acid and also the lipid hypertrophy, and also the other side effects. So ABC is okay for pregnant women, and it's also an alternative for patients who are not suitable for TDF. However, it has some side effect of the allergy. And also for D4T, D4T has been faded out of the stage. And the third class of drug is TDF. TDF is widely used in the market. However, it has some renal problem and also the bone density impairment. So you can see that osteoporosis may be a side effect of DTF. And have a look at the new drug in the NRTIs, the class, which is a TAF. TAF side effect is 1/10 lower than the TDF. However, there is another downside, which is body weight gain of a TAF. So you can see that these are the drugs not in use, and ABC and the AZT will also be faded out of the market. And it looks that the 3TC, FTC, the TDF and the TAF is widely used in the market. And for NRTI, there are big 4 drugs in the market. The first is efavirenz, and you can see allergy and hepatitis. The second group is NVP. NVP is gradually faded out of the market. It may have liver toxicity and allergy. The third one is ripivirine. Ripivirine is a NNRTI, so it also has its side effects. For example, allergy and the neural and the mental side effects. Another problem is the EGFR reduction, just like DTG. It is a kind of inhibition of the secretion of creatine. So it's a kind of a pseudo increase. And you can see for DOR or doravirine, the side effects is not listed. So it looks that this drug may have lower toxicity profile. So the third group of drug is the PIs. So this is the first core drug, which is very important in the heart. So it has a lot of problem like the lipid disorder and the GI side effects. And also you can see that there is a problem of renal stoning, and you can see that even though in the guidelines, the PIs is kind of alternative, not the preferred recommendation. So have a look at the newer generation of drugs, which is INSTIs. So you can see that how about the toxic side effects of this class? Is that perfect? It's not perfect. You can see that these are the 4 major INSTIs in the market. The first is RAL. The first drug, RAL, has a problem of rhabdomyolysis and also the allergy. For DTG, you can see that the DTG is now highlighted as the first line, preferred first line. However, it may also have a problem of a rash and nausea and the increase of creatine and the body weight gain. And EVG, you can see that this drug may also have a GI reaction and the increase and the decrease of EGFR, and it also have the neural disorder, mental disorder, and headache. So the blue complications refer to those adverse reactions higher than 10%, and the red ones actually are the severe ones. And also you can see that the big may also have a problem of EGFR and also the body weight gain. So these are the big four in the INSTI class. When we talk about the ART treatment, any drug will have side effects. This is something which is inevitable. And also there are some toxic side effects of accumulate. That is, there is a time lag between the development of a drug and the identification of the side effects. So some of the side effects will accumulate in the during the treatment. We have to keep an eye on the side effects. So for the time constraint, I have to finish 40 slides in 15 minutes. So it is a big job for the interpreters. It's a big job for the interpreters to interpret such a quick, such a rapid, fast presentation. So you can see that there are 5 major problems. You can see that the NRTIs actually are metabolized by liver. So there may be a liver toxicity. And also you can see PI and NNRTI and INSTI are metabolized by the liver. So liver problem may occur. Another class is renal disorder. You can see that for PIs and for NRTIs, they are metabolized by the kidney. So kidney stone, for example, may happen. And also some of the drugs like NRTIs and the PI or INSTI may have cardiovascular and metabolic side effects. And NRTI and INSTI may have toxic side effects related to CNS. So have a look at the liver damage. This is the incidence of liver impairment. So the incidence, so you can see that the incidence of liver impairment is higher than 10%, 10% to 30%. And also this kind of a DAD study indicated that the combination of efavirenz plus TDF and the FTC, you can see that it has a very high it has a very high incidence of liver toxicity. Compared with the regimens that's not containing EVF, you can see that the efavirenz will have a higher incidence of liver toxicity, and you can see that the INIs may also show that the INSTI are also metabolized by the liver, but it may also have a potential effect. ABC should be metabolized for the patients with a liver impairment because ABC is mainly metabolized by the liver. However, for other drugs, you don't need to adjust the dosage if the patient has a liver impairment. So the second class is renal side effects. So I emphasize that NRTIs and the PIs are metabolized by kidney, and also INSTI will inhibit the secretion of creatine by the tube. So that's why there is some effect on the kidney. So you can see that for NNRTIs, it may also have some kidney toxicity, which may be neglected by us. So we have to put an eye on the potential side effects. And in the TDF, you can see that the incidence of renal disorder is very low. However, in the reality, in the real life, the incidence of renal impairment of a TDF is 3-fold higher than the clinical trial. So that's why you can see that in the real world, the problem of our kidney is much worse than the clinical trial. We have to mind that. For the patient with some renal disorder or with some renal complication, what are we going to do? So this is the guideline in 2014 and in 2017. So for patients with EGFR lower than 60 or with some proteinuria, we need to stop TDF, and also we should stop NSAID. We should stop NSAID. And actually, it's difficult to manage the ward because once the patient has a fever, we may use ibuprofen or other NSAIDs. Those kind of NSAIDs will increase the toxicity on the liver. So this is the 2020 Europe guideline. This is a very good guideline. So you can see that this is this is the judgment of renal disorder based on EGFR, and also the ratio between creatine and the proteinuria. This is a very important. Now you can see that we will use the ratio between the albumin versus EGFR. So you can see that even though the EGFR is higher than the 30, if the ratio between the albumin and creatine is not good, the renal function is already very poor. So you have to mind that even though the EGFR is higher than 30, so you can see that these two indicators or parameters are very important. One is the EGFR, another is the ratio between albumin and the creatine. So those kind of new parameters are very sensitive for us to identify patients with a potential renal disorder. And this is the recommendation. If the albumin creatine ratio is not good, for example, the ratio is between 15 to 50, you need to consider replacing TDF with TAF. And you can see that in this case, you should avoid the TDF in those kind of cases, because TDF should not be combined with PI, because a PI will increase the concentration of TDF. So that's why PI should not be used together with TDF. If the urine protein creatine ratio is more than 50, and also you can see that if the EGFR is less than 60, or if the patient has the history of a kidney infection, you have to avoid the TDF in the regimen if the patient has those kind of problems. And for the dose adjustment of ART, you can see that only one drug need to be adjusted for the patient with renal disorder, and the rest of the drugs will not be adjusted against the renal impairment condition, because those drugs are not metabolized by the kidney. Only one NRTI is going to be adjusted. And how about the aged care and also the cardiovascular health? So for the new diagnosed patients, we need to screen the cardiovascular health, for example, the lipid and blood glucose testing to evaluate the risk in the next 10 years. And also you can see that this is the prevention, for example, stop smoking. The patient should quit smoking. This is something they must do. If the patient has hypertension, the blood pressure should be controlled at around 130/50. If the patient has the coagulopathy, you need to use some aspirin to prevent. One patient yesterday had the myocardial infarction, and we didn't have any time to run PCI, so we had to do thrombolysis beside the bed. So that's why you have to mind the coagulopathy or the the tendency of thrombosis, and the HbA1c should be lower than 6.5, and for the lipid, you can see that the LDL-C must be lower than 1.4. So if the patient already has some cardiovascular events, and you still need to continue with statin, and you have to be more stringent. You have to be more stringent with some LDL-C.
Here are other high-risk factors. For example, a recent events of cardiovascular events, or family history of cardiovascular events, or family history of ischemic stroke, and also potential atherosclerosis. He also demonstrated the impact on the lipid and glucose profile. This is a common risk to NRT, NRTI, PIs, etc. The previous table was one that I developed, and The statin has been used oftenly, and those are recommended. However, for the agents mentioned later, I'd like you to avoid. Here shows the medications that you need to avoid when patients have higher risk for cardiovascular events. The third part is central nervous toxicity. This is a severe condition. For example, EVF, you expect 40% of risk. Sometimes it is very severe, such as personality disorder. Recently, I finished a trial and we found more than 58% incidence of sleep disorder among these patients. However, they should be compliant to the regimen for the rest of their life. Therefore, we need to think of the necessity of some agents, for example, anxiolytics. And here are studies from 2012 for it mentioned that among 20% of risk from EFV, here are the risks across the board, except for the NRTIs. The other agents comes with central nerve damage. So the same is true demonstrated in this study, though there is lower incidence. For example, lower than 5% of neural-related complications. Therefore, we need to recommend the screening for psychological and neural function. This has been recommended by many guidelines. However, when we find significant findings, what should we do? Then we may learn from Youan Hospital in Beijing to streamline and categorize the proper treatment. For example, we need to screen patients for pre-existing risk. If if the patient has those risks, then you should avoid EFV. But in certain resource-limited scenario, patients are left with no other option other than EVF. Another category of toxicities are for the skeletal muscular system, in particular osteoporosis. So there are controllable risks and non-controllable risks. You can't modify age and race, but there are factors that you can moderate. For example, weights, you need to increase the weight to a certain level. You need to stop smoking. You need to increase the intake of good protein, gluten quality protein. Here shows the incidence of osteoporosis with the red and of osteoporosis, and on the right hand side that is China data. Also, osteoporosis has been found quite prevalent among our patients, and these risks are inter-associated. Different agents may have different level of impact on the bone marrow density. This guideline also talk about the risk factor according to different age groups. Then you need to scan the patient with DEXA. And it should be age-based. For example, when they are above 50 years old, and then you use different parameters for the elderly versus the younger population. All the guidelines mention that you need to avoid TDF, and you can choose TAF. If osteoporosis already exists, then you need to transition to a TDF-free regimen. There are other things that we can do. For example, change of lifestyle, increase intake of calcium and vitamin D, and the use of hyaluronic acid or zoledronic acid. There are studies indicating increase of bone marrow density. However, I don't have experience on the use of zoledronic acid in our service. And we need to pay attention to these chronic conditions. We know that these agents are effective for those conditions, and we need to transition the patients to a regimen that is safe and sustainable, because the patient should be on the ART for the rest of their lives. And we need to tailor the regimen to the patient's needs. We are expecting good results from ART. However, they always come with adverse reactions. Therefore, we need to monitor various function of various organs and systems. Thank you.